precise in treating diabetic patients, and how can we personalize our treatment in view of the various and complicated and interlinked variabilities that do exist. I don't really need to talk about the burden of diabetes and CKD. We all know what's going on. The very disappointing news is this graph, a little bit old, is just the same if not worse. Diabetes is still the leading cause, to be followed by hypertension. Maybe in Egypt, hypertension comes first. The catastrophe is this thing is happening in the lower income class countries and the lower middle income class countries such as ours, adding severe restrictions and burdens on the economy when it comes to healthcare provision. Naturally, being a diabetic and having CKD would put you at a greater risk of all-cause mortality and also all-cause cardiovascular mortality associated with the various interventional techniques and adding to the cost. So being diabetic and having CKD, you are almost double risk for the occurrence of these complications and mortality. So far for that, let me take you briefly through the pathogenesis. Pathogenesis is a very interesting field, and over the last 25 years, there has been a lot of work and publications in this regard, and maybe more than 20 years I got so interested in diabetic nephropathy, and I thought at that time we are going to solve the pathogenesis and find a single pathway, but alas, up to now, things have not changed so much, although we understand a lot. Everything starts by the terrible hyperglycemia, as you can see, which would reflect on the production of reactive oxygen species, which were thought to be at one stage the missing link to everything, which is not the case. This could affect, of course, the nuclear factor capability to start to produce various pro-inflammatory cytokines that would subject the genes to produce sort of fibrosis, increased extracellular matrix, which is the hallmark of the pathology and the expansion of the mesangium. Another way of looking at it, as you can see here also, transformative growth factor beta and angiotensin II, under the influence of the hyperglycemia, also share this together with the other factors. We have a stimulation in this way of other factors such as the transforming growth factor beta and the connective tissue growth factor and another growth factor. Well, eventually all these pathways will lead to a dead end of fibrosis and expansion of the mesangium. Looking to things in a little bit in a different way, you would find the genetic setting responsible about this. Not all diabetic patients are supposed to get this particular complication. Up till now, as far as I remember, we have found more than 280 genes in which the polymorphism occurring in these genes have been linked to disturbances in metabolic pathways that would eventually lead to disturbances ending in this pathology. You always have to understand that shear stress occurring with the hyperglycemia and the associated hypertension is another major insult to the vasculopathy, not only of the glomeruli, but of all the vascular tree of the body. Oxidative stress, again, related to the hyperglycemia and the excessive formation of advanced glycation end products, the disturbances occurring with protein kinase C. As you can see in this very busy diagram, eventually patients would get disturbances in the pathways that would reflect on mesangial expansion, eventually nephropathy, manifesting clinically by proteinuria, which, if is going to progress, would lead to the glomerulosclerosis and the final stage of end-stage renal disease. This is too much. This is too much. And because it is too much, I have been seeing it for the last 20 years like this cartoon. Every scientist is looking at the elephant from a little part of it and trying to describe what it is, but no one is able up to now to say it is an elephant. have solid evidence in our hands is controlling hypoglycemia and other associated comorbidities, as I will come to show, is the only thing available. Can we do this? Let me show you if we can or we cannot. I don't have to tell you about the stages of diabetic nephropathy, starting from the incipient till the end, with proteinuria increasing all the time. You are all aware of this, of course. But the interesting point is over the years, well, this was classic teaching, what I showed. Over the years, things have changed. Now we have patients who have a decline in their GFR and they are normal albuminuric. What's this? What about the stages? Why is this happening? So not all patients with diabetic nephropathy nowadays are having albuminuria as they used to. So the non-albuminuric renal insufficiency is a reality and happening and making the diagnosis more and more difficult, because this was used as a biomarker. Let me say, you find microalbuminuria, then you will think of diabetic nephropathy, but you still know that microalbuminuria is a predictor of cardiovascular morbidity as well. Now we are talking about an entity which is not little, of patients passing into diabetic nephropathy without this biomarker, the microalbuminuria. Even it has been defined by name as the silent diabetic nephropathy, where patients, if biopsied, you will find various tubulointerstitial lesions and vasculopathies and no evidence of proteinuria whatsoever. The clinical manifestations of the kidney disease, according to this meta-analysis of various trials which lasted for a very long time, could really show this fact about the decline of microalbuminuria, the thing that we believe so much as a predictor of diabetic nephropathy. If you look to their findings, you would find, astonishingly, the prevalence of albuminuria is decreasing. You would think, well, that's good. Patients are improving. This is not happening. They are getting more worse. Prevalence of reduced glomerular filtration rate rose almost double, from 9.2 to 14.1, and the prevalence of severely reduced glomerular filtration rate even increased to more than the double. Why is this happening? We all have been for years using ACEs and ARBs, and we understand the importance of ACEs and ARBs and so forth, and it seems that using all these together with statins is helping in reducing the proteinuria, but it's not solving all the condition of diabetic nephropathy, which seems to have multiple etiologies. Sometimes there could be some clinical manifestations that could aware you that a particular patient is going to have a diabetic nephropathy. It comes with the elderly, the males in particular. Those who have associated hypertension and anemic, and naturally if they have a little bit of a decrease in the GFR and albuminuria, it could be helpful. Another view looking to the matter said, is non-albuminuric renal insufficiency a sort of vasculopathy? Yes, because some biopsies done did show interstitial lesions with various pathological affection of the vessels, because the etiology is diverse. We used to so much say if a patient has retinopathy, which is valid for type 1 but not so much in type 2, he would have diabetic nephropathy, and the stages don't go hand in hand. This again has been turned all over and is not any more a fact. Maybe 15, 20 years ago I was talking about this same point and very strict about it. Now things are changing. Now this is a wonderful pooled meta-analysis of 48 studies that looked into 4,875 patients in various centers, and they looked to the biopsies. The biopsies of these patients were mainly deceased patients, and they took biopsies from these diabetic patients, whether they had renal insufficiency at that time, source of CKD or not. Astonishingly, when they looked at the biopsies, you can see the spectrum of glomerulopathies from focal segmental to whatever. So it's not just diabetes and diabetic nephropathy as well, adding to the difficulty of the problem. Well, not to talk any more about this particular point, but just to show you what we are dealing with, let's see how we can manage this problem and how can we help those who do develop diabetic kidney disease. I believe so much in precision. In treating patients, you have to be very precise, you have to know your limits, you have to know what you are dealing with. Precision in medicine, in life in general, is something very, very important. وهو ده اللي بيفرق ما بين الدول المتقدمة والدول اللي لسه نفسها تتقدم. Precision, الدقة, is something very important. Hence, you have to be precise and then you have to be choosy. I'm not going to give a long-acting sulfonylurea to someone who has a GFR of 45. Definitely, I'm going to make this patient suffer hypoglycemia that can really be a catastrophe and it may even kill him. So you have to individualize your therapies accordingly. How is this? We are very lucky today than I was when I was graduated from medicine. Our drug armamentarium is full of new drugs. The wonderful thing about these drugs that they can be used even in CKD patients as long as you know how to use them. The good thing about these drugs, you can use them together, you can use them with metformin, with sulfonylurea, you can mix them with insulin, wonderful drugs. And the greatest thing about these drugs, now they are making drugs that are offering benefits beyond glycemic control. It's very easy to control blood sugar by insulin and maybe sulfonylurea. But to give a drug that has added value, as they say in economists now, added value is something of benefit, as I will show you. The most important thing, looking at this bird on top of the building and looking at the other buildings in what is known as a bird's eye view, you have to have a holistic approach towards treating the patient. And this is the calamity. This is why there is failure. Maybe you are controlling the blood sugar for the patient, but all these other circles of catastrophic things are not looked at. Dietary intervention, exercise program. I can tell the patient to do that, but he's the one who's supposed to do it. I cannot do it for him. I can't give him an injection to make him not exercise. I cannot. Smoking, aspirin, lipid lowering, this is another story. All this holistic approach could achieve definitely a better outcomes when it comes to treating diabetes at large and preventing the progression of CKD in particular. There are things I can do nothing about. Those ones written in red, whether a male or an elderly person, or ethnicity or susceptibility and genetic considerations. I can't do anything about this, but we really don't have an excuse in tightly controlling the blood pressure, taking care of the body weight of the patient by insisting that he should reduce his diet, mild exercise. We're not asking patients to go and play squash or tennis, just mild exercise. People who are that lazy and just watch football over the TV, they could do much better if they walk around just for 20 minutes every day. Just 20 minutes is good. It has been plotted against survival, just 20 minutes a day, and it showed very positive results. Naturally, poor diabetic control is another important issue that we are trying to help. All the standards of medical care that have been published over the years have advocated just what I said, and always over and over, this American Diabetic Association over has been said and will always be said: optimize glucose control, lower your blood pressure to the optimum as long as the patient can withstand it. This is very important in order to achieve prevention of complication. Let me take you to another point, which is the intensive control of blood sugar. And these facts have been well addressed a long time ago by the DCCT and the UKPDS. The salutary effects of the intensive therapy have been well demonstrated in these wonderful mega trials that lasted for more than 8 years. So this is a fact. You tightly control the blood sugar, you do a lot of benefit to your patients. Lately, this publication that evaluates 7 trials involving around 28,000 adults, again and again showed that intensive control of the blood sugar could really reduce the risk of microalbuminuria and its progression. This is important, and all of these trials have showed this possible reduction, which is up to 14%. I'm not happy about this 14%. Why isn't it 60 or 70 or 80? Why? Because there are other things that should be done, they are not done. It's not enough to give the patient RAS blockade and control his blood sugar and expect his microalbuminuria to be better. There are other things to do. Mind you, even if the other things are done, there are still patients who are not going to respond. We see it, we do it with patients, and this is what we see. There are other considerations as well, but we have to do what we have to do in the proper way in order this 14% that everybody is happy about should be much more than that. Mind you, since about 10 years, a new entity of diabetic nephropathy has been shown. They are called the regressors. Out of the blue, they start to regress and become better without ACEs, without anything, and no one had an explanation for regressing pathology and regressing lesions. Of course, if a patient is going to receive pancreatic transplantation, it has been shown by Her2 many years ago that after 10 years, all the pathology that was in the kidney has improved and has become normalized again. But who can achieve this by chemicals? I think this is something very difficult. This 14% فرحانين بها قوي، أنا مش فرحان بها. We have to do a lot of hard work to make it more. Coming to the kidneys, our beloved kidneys, we have another situation. We try to intensify our blood sugar in our patients, and you know the insulinase and all this about the insulin. When the kidney starts to fail, you start to get accumulation of the hypoglycemic drugs, particularly the old sulfonylureas, and then you are facing a major problem of hypoglycemia. So you have to be precise again in choosing the specific therapy for this particular patient and give him what he really needs in order to control his blood sugar and to avoid this serious complication. We have been so many years depending on glycated hemoglobin and its levels, and it is a standard. All the publications have used glycated hemoglobin. We understand it so well. We can compare studies together by glycated hemoglobin. You'd come to tell me, but this is strange because you cannot apply glycated hemoglobin to the CKD patients because he's taking EPO, taking vitamin C maybe, he's anemic, vitamin B12 affects. Yes, I consider all these factors that may lead to false elevations or false low levels of glycated hemoglobin. You're going to tell me use something else, glycated albumin, for example? Well, I need research over long years in order to really appreciate this new biomarker or whatever you want to name it as a standard thing to use in CKD. So, right now, the recommendations, even in our CKD patients, we are still going to use glycated hemoglobin to assess our diabetic patients عشان ما حدش يتكلم في النقطة دي تاني. Chronic kidney disease and intensive glycemic control has been looked into by the authors in Kidney International, and it was a warning signal to physicians treating CKD patients. And when they looked into these studies, they saw horrible complications when they started to normalize the blood sugar in the CKD patients. الشطارة ان انت تبدأ بدري. Once the patient has progressed to CKD and then you want to try to get his blood sugar back, to revert the microalbuminuria, you are already late. You are already causing damage. If you look, I don't know if you can see the slide or not, non-fatal myocardial infarction, strokes, and various cardiovascular morbidities were shown to be higher in CKD patients that were advocated to have normalization of blood sugar. We can't do this in CKD patients. You can do it early before the catastrophe starts. So the recommended goals is to be a little bit relaxed when it comes to glycemic control. You shouldn't treat glycated hemoglobin less than 7 in patients who are at a risk of hypoglycemia, and those even who have cerebral morbidities or advanced heart failure and so forth, I would caution you to give it, to keep your targets a little bit more than 7. If a healthy person is diabetic, it's so good to take him down to below 6, yes. But this particular patient will suffer a lot if you try to achieve this control, in spite that you know that glycemic control is very important for so and so and so. But we have a delicate situation that needs individualization of therapy because there are benefits that outweigh the risks. So individualized therapy in such patients, achieving these seemingly accepted targets. Another thing, don't try to be a hero for someone who's above 85 years and try to normalize his blood sugar, because you have to consider the associated morbidities and the lifespan of the patient. يا فرحتي ظبطوا له سكر ومات بهايبوغلاسيميا. That's really not good medicine. So this is part of individualization of the therapy. We cannot be dogmatic in our approaches and follow guidelines strictly. Guidelines are simply guidelines. And when you read a guideline today, the guideline today is not fitting so much for today because it has been hard work many years before, maybe during the last 4 or 5 years since the guideline appeared, there has been things new, but still guidelines are good. I wouldn't recommend at all, not me. I mean, it is not recommended to use ACE inhibitors in non-albuminuric diabetic patients, but definitely when you have albuminuric patients, you should use the ACE or the ARBs in order to prevent the progression. Always again and again we have to insist on the target blood pressure control, apart from the occurrence of disturbances, chronic perfusion if the patient is mildly ischemic, yet always try to target blood pressure less than 130 over 80 for those who are microalbuminuric. Using the ACEs and ARBs definitely all over the years the trials have shown the benefits. I'm not going to talk much about this, but let me take you to another point as a part of the holistic approach, which is dyslipidemia. All the trials over the last 20 years showed us the benefits of statins. They are not just lowering the lipids, but they have other benefits. They are anti-inflammatory and they are very good. Mind you, these lipids, when you have LDL swimming in your circulation, it bombards all the endothelium of all the blood vessels, including the capillaries of the glomeruli, which have been denatured by diabetes already and started to be leaky. These small particles, the LDL and even the very low density particles, could escape وترشق في الميزانجم, then it starts to initiate inflammatory reaction. That's how diabetic nephropathy is so diverse in its pathology. Using statins is good. It has been shown in various trials that it could not only ameliorate the progression of diabetic nephropathy, but other glomerulopathies. Over the years, they have tried multiple things: mycophenolate, heparin sulfate, TZDs in general have been shown to offer benefits, not only in diabetic nephropathy, but not one single thing is, I can say that it is on its own is effective. Now passing to the last part of my talk, which is going to be around the hypoglycemic drugs, showing you what we do have as drugs and new drugs in our armamentarium today, which gives us no excuse to handle every hypoglycemic patient in an elegant, precise, individualized way. This is the list. I don't have to go through the names, but let me start. I'm going to talk about some drugs I'm sure all of you are aware, but I just have to touch all these drugs in order to have a consistent presentation. And let me start by metformin. A lot of treating physicians of diabetics think the metformin we do know as nephrologists, is nephrotoxic. It is not nephrotoxic, of course, but there are warnings. When the GFR drops, you should take care. When it's a little bit above 45, you can have the dose, but when it reaches 30, please stop. You can use the serum creatinine according to the guidance here on the right-hand side of the slide, but metformin is a very good drug if you know how to use it, and keep on the watch. Lactic acidosis does happen. It is not common, but it does happen. A patient who has heart failure, who has infection, and diabetics seem to be like that so many times, are more vulnerable to have lactic acidemia, particularly if they are taking metformin. Sometimes a patient will go and tell him, no, the metformin, to a doctor will tell him metformin is toxic to the kidney. Sure, it's not toxic to the kidney, but you have to consider reducing the dose, and you have to keep on using this wonderful drug for the added values. Looking at the sulfonylureas, you can see that the glipizide does not need any dose adjustment in comparison to the others. Of course, glyburide, very old drug, we're not using anymore, should be avoided. Glycoside is not present anymore. So glipizide seems to be safe, yet in advanced CKD, you may still see cases of hypoglycemia. TZDs are wonderful drugs. They improve the insulin sensitivity, they increase the insulin receptors on the surface of the wall. They're very good for hyperinsulinemia, which is a problem in type 2 diabetes. Also, they are of benefits in the treatment of diabetic nephropathy when it's present. But our patients, as their GFR progresses, they have a tendency for volume overload and hypertension and so forth. So you have to be cautious when you use the TZDs. We're not using anymore the alpha-glucosidase inhibitors, although just a point of noteworthy you should know, acarbose is a very good prebiotic, and I'm interested so much in the microbiome, and it has been shown to be very helpful in this regard. But this is just something to note related to acarbose and migritol. I don't think we are using these drugs anymore. Now, coming to the newcomers, the DPP4, the dipeptide peptidase 4 inhibitor. What are these drugs doing? We understand that there is incretin. Incretin is a hormone released from the gut. There are two incretins, the glucagon-like peptide 1 and the glucose-dependent insulinotropic peptide. Both of these incretins are released and rapidly degranulated and metabolized by the dipeptide peptidase. Now we have an inhibitor to prevent this, so we can prolong the action of the GLP-1, which is anti-glucagon and has some wonderful metabolic effects, as I will show you. And what we have on our hands now from this class of drugs, we have the sitagliptin, saxagliptin, linagliptin, and vildagliptin. All of these drugs can be safely used in chronic kidney disease up to GFR less than 30 if you're going to have the dose. Linagliptin is the only one that you can use without any dose adjustment. Nevertheless, you reduce the dose or keep the full dose, you will get a good glycemic control in your CKD patients, and they are not causing hypoglycemia anymore. As I said earlier, the new oral therapies will have proven benefits beyond glycemic control. It's nice to control your blood sugar and at the same time delay progression. It's nice to have a little bit of modest weight loss, or at least being weight neutral, which الوزن زي sulfonylureas. It's not bad to have a drug that could help in reducing the blood pressure, to help out with the anti-hyper medication, anti-hypertensive medication the patient is taking. And how about cardiovascular protection and nephroprotection also? Let me show you this. Coming to the first class with such marvelous added values, the DPP4 inhibitor, nephroprotection. I don't have really human experiments a lot to show you, but let me take you through this slide. I'm not going to take through you all of this slide. It's just showing the wonderful actions of peptide 1, which exerts its actions through specific receptors that is present all over these organs. And just look into any box, you will find how much beneficial this GLP-1 is. But we are nephrologists, we are concerned about the kidney. We have to realize that the GLP-1 is causing diuresis and natriuresis. This will definitely help in controlling the blood pressure. This is number 1. Now, number 2, and in this recent publication, the GLP-1 has been shown also to inhibit the effects of renin and the transformation of the RAS, which will lead eventually to vasoconstriction and so forth. The story about reactive oxygen species in relation to hypoglycemia, again, this is ameliorated by the GLP-1 or the Gp1 receptor agonists, which are the incretin mimetic. So, ladies and gentlemen, we have great added value using DPP-4 inhibitors and incretin mimetics in prevention, possibly, I say these are animal experiments, possibly, in humans in ameliorating the progression of chronic kidney disease. This is the thing I found that was a clinical trial showing that linagliptin is better than the placebo in regard to reduction in the occurrence of progression of nephropathy. This is good. I don't know if this is related only to this molecule or it is a class effect. We need the other molecules to do such experiments in order to conclude the results, because these people will always say it is a molecule and I have to understand their point. The other newcomer is the SGLT2 inhibitors, some wonderful new drugs. I remember when I was in the States some 15 years ago or 12 years ago, and someone started to talk about this. This was not a drug at that time. It sounds so amusing. Someone is going to piss glucose in the urine, and this is how he's going to control his blood sugar. It sounded amazing. Now it's a fact. Not only is it a fact, but the SGLT2 inhibitors also have great added benefits in cardiac protection and not only in control of type 2 diabetes mellitus. Mind you, of course, you can combine them with metformin, DPP inhibitors, insulin, whatever you like. Just this diagrammatic representation to the left-hand side, the normal thing about the glomerulus and the site of presence of the sodium glucose co-transporter 2 and 1. Let us talk about 2. When we're talking about 1, it's mainly in the gut. When you have diabetes, the SGLT2 is super active and reabsorbing all the glucose and some sodium. When you give the drug, it blocks this action, and then the sodium and glucose start to be wasted in the urine. This is as simple as I can say it. Does this have any benefit beyond controlling the blood sugar? Well, the EMPEREC trial and also the CANVAS trial I'm not showing you today, who had other renal endpoints, showed benefits beyond glycemic control in their patients, up to 39% reduction in the progression of diabetic nephropathy. Mind you, for heart and heart failure, they had a really higher, I think 59 reduction in the incidence of heart failure patients being hospitalized. Both the EMPEREC trial, which addressed the empagliflozin, and the canafluclazine trial was the CANVAS one, did show these wonderful things. So you're not just controlling your blood sugar, you're getting more benefits. Here is the heart. You can see there is less cardiovascular events and less heart failure. And I didn't put a slide to show the renal results in the sake of time, but if you go back to the trial, you will find what I said is true. The last thing I'm addressing is the thing itself, the GLP itself, the GLP analogs, or the incretin analog, or the Gp1 receptor agonist. These drugs are injectable, and this is the bad thing about it. They have some gastrointestinal manifestations, nausea, vomiting, naturally, because they are delaying the gastric emptying and working on the receptors in the brain, giving the patient satiety. That's why they are wonderful in weight loss. You wouldn't recommend them to all patients, not just because they are expensive, but if you have someone whose obesity is a real problem, they really work fine. They really work fine. But again, the GLP analogs are not to be recommended when the patient GFR drops below 30. So the effects in CKD is better, yes, but mind you, when the GFR drops to 30, you better avoid using the incretin mimetics. Is this all the story about it? I will tell you more. The incretins, as you can see from this diagram, has some wonderful systemic effects related to obesity, proteinuria, nephroprotection. So they are really favorable when coming to treat diabetic patients with CKD, particularly those obese patients that I've been telling you about. So the armamentarium is full of things that you can use in combination. You have no excuse not to control your glycated hemoglobin to the target according to your individualized approach to a specific patient. I said, is this all? No, it's not all, because just tomorrow here in Egypt they are launching a new once weekly injectable form of incretin analog called dulaglutide. And the good thing about this is just a single injection once a week. So it makes things very easy. I think it costs around £2,000 a month, I'm not sure, but this is what I heard. The good thing about this new form, the dulaglutide, that it has the benefits of being used in CKD right up till the end. So here we are, an added benefit. They're very happy about it and they're going to launch it tomorrow, but I don't think they will be happy for a long time, because I just came across the SUSTAIN-7 trial, which has been published last month, saying that another incretin analog, very much similar to this one, but is much better, is called the semaglutide, which has been shown to be superior to dulaglutide. It does produce glycemic control and reduce body weight and has a safety profile just like the dulaglutide, but was superior in all these points in comparison. Anyway, this is still a phase 3B trial. Right now we have the dulaglutide and will be present in this country. 2 more slides. The pharmacokinetics and tolerability of this drug has been compared to the dulaglutide, and these are the results, that it is well tolerated and we do not need any dose adjustment and renal impairment. Just a quick slide to show you the various forms of insulin. I advocate so much the latest insulin we have at hand, which is the Digludec. It's a wonderful insulin. It is really a long-acting when you compare it to Glargine or Detimar. It really covers the 24 hours and even more. It does not peak at all. You can combine it with whatever you like. So this is a wonderful formula, and you can use it in CKD and tailor your dose in accordance with avoidance of hypoglycemia. A final 2 slides just to show you all the drugs together, and I lately added the dulaglutide and semaglutide that can be used all through the stages of CKD together, comparing it to the other drugs. I'm not a great fan of algorithm, but I had to put it. I'm not going to go through it for the sake of time, and just conclude and say that better glycemic and blood pressure control can really delay the onset and slow the progression of kidney disease in diabetic patients. All the hypoglycemic agents are either contraindicated or require dose adjustment. And the good thing is the new medications that have been approved can be used safely in patients with CKD. Not only this, but the other benefits beyond glycemic control. This is what medicine is seeking, one pill to do more than one action. My take-home message again, the holistic approach together with the precision